Hi guys, welcome to another episode of Maruthuvar on Call Real Take. This is Dr. Dona, and in this episode I have a very special guest here with me today, Dr. Lahvanya. Hi Lahvanya, how are you?
Hi, thank you so much for having me on here. I'm really good, thank you. How are you?
I'm good, thank you so much for coming. I can't wait to know more about what you've been up to and how you got to where you are.
இவன் பாடிய துதியை கவனித்தீரா? துதியை இன்னும் ஒருமுறை பாடு.
Thank you. It's not that exciting, but thank you.
So why don't you tell us a little bit more about what you do?
Sure. So I'm Lahvanya, currently a GP ST1 in South London. I went into GP training straight from F1 and F2, so I didn't take an F3. GP training is 3 years, and I'm doing my hospital rotation year first, and I'm currently on geriatrics. Yeah.
Okay, so you're in geriatrics even though you're doing GP. So just for people who, don't know anything about the rotation so far, how does it work then?
So GP training at the moment is a total of 3 years, and one of the years has to be a hospital year, and you do hospital-based rotation. So that's either 6 months, 6 months, or 3 lots of 4-month rotation. So in my case, it's 3 lots of 4-month rotations. So you can have your hospital year either as an ST2 or in your ST1 year. Mine was allocated in ST1, which I think I prefer because we have the exam in ST2. And in ST1, I've got geriatrics, and then next week I finish geriatrics and move on to GUM. So it's like GUM clinics and genitourinary medicine, so that should be interesting. And then I end on pediatrics.
Okay, that makes sense. And then it's basically like F1, F2 general rotations, and then the next 2 years you're going to be in GP.
Yes, exactly. So my kind of GP VTS, they let you do an ITP if you want in SD2. So I think they call it the integrated training program. So my ITP is in palliative care. So each week, 3 days I'll be in GP and 2 days I'll be in like a hospice or hospital-based palliative care, just for more experience in that area.
Okay. And do you get to pick the kind of specialities that you do?
So you get to rank them. So when you get, your job, you get to rank which rotations you'd like. So I kind of made sure to avoid ED. I think I really made sure to avoid obs and gynae as well, because I know those are really hectic. And I had obs and gynae in F1, so I thought, okay, it's fine. So yeah, these are the ones I chose, and I was quite happy with them.
Okay, fine, I see. And then do you know where you're going to be in terms of location for the next 2 years?
So wherever you kind of do your entire GP training, that's where you are for the whole 3 years. So the hospital I'm at changes. So next rotation I'm at a different hospital. But it's basically all the GP practices around that area. So it's within like a certain area. It doesn't change much.
Okay. What kind of made you pick GP as a speciality?
I think I kind of always saw myself being a GP. I think mainly because I wasn't very passionate about a particular specialty. And throughout medical school and throughout F1, F2, when I rotated throughout different specialties, I liked it, but I couldn't see myself doing that like throughout. And a bit also in terms of work-life balance. I think I really hate doing night shifts. So I think a career where you don't have to do nights really kind of drew me towards GP as well. And I like the continuity of care. So you get to see the same patients. So I think those are the reasons. But I think I always knew I wanted to be a GP.
Did you have a GP rotation as an F1, F2?
No. So interestingly, no. And I was supposed to have a taster week, but then I think it was really difficult to organise, so I ended up not having that either. So it's a bit of a risk that I've taken, just going straight into GP without actually working in GP. It's probably a bit silly. I wouldn't advise it to other people. But I really liked it during medical school, the rotation I had. So I'm just hoping that I like it. And yeah.
Okay, I see.
So I think in terms of being a GP, I think one of the things I probably don't like as much is there's not as much of a teamwork element as you get when you're in hospital. Like right now, I love the team I work with. I like that when there's a problem, you can rant about it to like everyone in your team, and it's like a joint decision. Whereas I think GP can be a bit isolating because it's just you, your patients, you're left to do the jobs, you're left to make that decision. So I think that's a real con of GP. But I think you can agree, working in the NHS, just having access to like a computer and like a chair to sit on, that really draws me to GP as well, because I'm fed up of at work, like there's no working computers and you've got to get in early to get a computer. So I think that's a pro.
Okay, yeah, that makes sense. And then in terms of anyone thinking of applying to GP, is there any like specific rotations you would advise them to look for in F1, F2, apart from the GP rotation itself?
Yeah, of course. So when I was applying for foundation training, even then I kind of knew that eventually I'd want to become a GP. So I made sure that I had obs and gynae, pediatrics and psychiatry. So I had all three of those rotations across F1 and F2, which I think is nice because those are things you commonly see a lot of in GP. So I would advise people to try and get at least 2 or 3 of those specialties in your foundation training. And also I think as a GP, you don't need a lot of surgical rotations, for example. So I think in a way, medical rotations are a bit more suitable for a future career in GP. So I think this is my third like medicine rotation now on Jerry's, and I think I really found that useful. I've not really had a surgical job. I think I strategically avoided it because I don't really like surgery, but I think for a career in GP, you don't need it as much anyway. So my advice would be obs and gynae, peds, and psychiatry. Try and get rotations in those, and a GP rotation if you can. If you can,
or a taste a week, like Lahvanya.
or a taste a week. Don't just think, oh, okay, I'm just going to go into it. Like
I'm sure you will be fine. And then in terms of the application process on Oriel, what sort of things do you need, and portfolio wise?
So I think a really nice thing, if you're lazy like me, you do not need like a really interesting portfolio. When I was applying, I think they had a box where you had to type in a paragraph about why you wanted to be a GP. So I just said, I like being a generalist, things like that. It didn't ask for publications or any poster presentations you've done. We don't even have an interview anymore for GP, whereas used to, I think pre-COVID, there used to be an interview. So I'd say just focus on your MSRA and try to really score highly on that, and it'll put you in a really good place to get a location you want, which I think is important.
Okay, so in terms of the ranking, it's solely based on MSRA then?
Solely based on MSRA, yeah. For now, solely based on MSRA.
So what are the specific tips for getting good scores on MSRA?
Good scores on MSRA. So I think my score was quite average. I got, I don't mind saying, 539. And initially, because I only applied for places in London, because I was like, okay, if I don't get it, I'll take an F3. I got no offers. So even if that happens, like, don't worry too much, because through the upgrade process, you get put higher and higher, and I ended up getting my first choice. So I went from none to getting first choice. But answering your question in terms of resources, I used Past Medicine. I think if you're in medical school, if you're doing MSRAs, it's the best, Past Medicine. So do Past Med. And I also used a question bank called MCQ Question Bank. It was a bit easier than the exam, MCQ Question Bank, but they were very similar. Some questions were very similar. But I think in terms of difficulty of the exam, Past Med is quite accurate.
When you applied, did you just apply for GP, or did you apply for other things as well?
So I just applied for GP. Primarily because I didn't really know what else I'd want to go into. I was quite set on GP, and also because I didn't have time to do like a lot of applications because I was in F2, and so I just thought, okay, I'll just apply for one. Last year, that didn't matter as much, but I don't know if you've heard about what they've done this year. It's a bit cheeky of them. So what they've done is, there's exams across January and February, but if you've applied for only GP and psychiatry or one or the other and no other specialties, you sit your MSRA in February. If you say added on like obs and gynae or radiology, you get asked to sit your exam in January.
Oh.
Yeah.
Oh, okay.
Yeah. So I'd say if you want that extra time to revise and you're just kind of applying anyway and just putting 2 other specialties without actually wanting to go into it, think twice, because you might lose out a month on revision.
So in terms of like special interest and locuming, is there like any speciality that you are thinking of?
So I think the more and more I kind of look into different things, I think dermatology will be something really interesting to specialize in. And I think pediatrics as well. There's loads of options for you when you get in there. And medical education is something I'm interested in too. So that's kind of what I've got in mind at the moment. But definitely, like, there's loads of things that you can dip in and out of when you're a GP, which is nice.
Yeah, I think that's really interesting what you brought up, because a lot of people, like as medical students or even as F1, F2, they are sometimes not aware of loads of options that are available to them. So they think that being a GP is just being a GP. Actually, you have, where I work in my ED, we have like a special hub where GPs actually come in and do a bit of ED GP like mixture kind of thing. Then your experience so far, is that any, I don't know if that's any different to F1 and F2, but is there anything you want to say?
I think in terms of, I think everything around me is similar. Like, you still have a portfolio, you still are rotating around every 3 months at the moment because I'm on the hospital rotation. But I think the difference is after you finish F1 and F2, you do see that difference in yourself in terms of how you deal with things. So I think as an F1 or F2, you're put in these situations for the first time ever. So it can be really daunting, but as you kind of get used to the system more and more, because obviously, like, we're in our 3rd year of working now, it gets a bit more easier to deal with, issues you face at work, or people being rude to you, or just the NHS being a bit slow in general and dealing with difficult patients. You get a bit better, and it gets a bit easier to deal with it. You still have bad days, but I think that's the main difference I've noticed in this year of working so far. I think I deal with things a bit better than in F1 and F2. In kind of F1 and F2, if, say, I'm on the phone to another specialty and like they're unnecessarily being like really rude or like really condescending, I think you kind of think, oh my God, okay, and you doubt yourself and you don't say anything back. But I think now I'm a bit better at being a bit more assertive and saying, that's not the way you're supposed to speak to someone.
Or anything, any case you saw or any particular experience that you've had that made you think about an alternative to medicine altogether?
I think definitely like some, because I'm currently at like a DGH hospital, and some of the ward cover shifts, I think if someone told me you're going to have to do ward cover shifts for the rest of your life, I think personally I would start looking at an alternative career. Knowing that, okay, I only have this many shifts of that left and then it's done, then that's okay. So I think that I find really difficult, just because the understaffing shocks me. Like when you're on ward cover and there's just one reg for clerking and ward cover, and if you're in a really bad situation, it's just you, whereas during the day you'll have a whole team of doctors. I find that shocking, because so many people want to get into training, but they make that really competitive. And the understaffing levels in hospital kind of make you think it's not really sustainable to work in a place like that. Like, if a job, how I see it is, if a job is making you really unhappy, unwell even, then you should consider looking into something else. And I think if it ever gets to that point for me, then I will look into another career.
Yeah, definitely. And yeah, it shocks me as well. During the nights and evening, it would literally be so few doctors. And then in the morning at like a random 9 o'clock, you have like 5-6 doctors.
And you're overstaffed.
There. And then you're like, why? I don't understand the point of this.
It's ridiculous.
But apart from ourselves as well, I think sometimes it can lead to unsafe patient care, not because we're being unsafe, it's just because of the system. Like, we can't be in 2 places at once.
Exactly. And I think, with all the things with strikes and, junior doctors leaving the country and all of that stuff, or leaving the profession, I think people often just relate it to pay. But I think a big part of it is because we feel like we can't do our job properly in an environment where it's so under-resourced and understaffed. And it kind of frustrates you because we come into this profession to help people and make people's lives better. But when you're in an environment where you don't feel like you're helping people because you've got like 50 different patients to look at, then I get why people get to that point. Yeah.
So just leading on from what we talked about, do you think this is one of the big reasons where a lot more people are applying to GP? Because I know a lot of my friends, they don't actually enjoy GP, even if they've had a rotation. But the sole reason they're picking that is because they don't really want to do the speciality they actually want to do. Do you think that's a problem?
I think it's a difficult one because, you know, like I wouldn't say that GP has its own difficulties as well, from what I've heard, like, you know, decision fatigue and a lot of admin, but don't go into it just because of the work-life balance. But then at the same time, if someone did do that, you've got to really think about that decision, because it's true, work-life balance is important. Because I think I saw an Instagram reel that day, and it was saying how we often decide what we want to do in terms of our career in our 20s, but we don't realize that we're going to have to do that in our 30s, our 40s, our 50s. So that's why I think, like, if I'm tired of doing night shifts now, in my 30s and 40s, I'm going to be exhausted. So I do understand why people think about work-life balance, but I think if you go into GP just because you don't like anything else, I don't know if that's a good idea, but yeah.
I think it's very subjective.
Yeah.
I think what people need to understand is that if they really, really hate GP, but the sole reason they are going into is work-life balance, then, well, you're going to have to work at something that's you don't like anyway for the rest of your life. So I think it's an important thing that is quite personal and subjective, isn't it? But it's something for people to think about as well. And then talking of a lot more people going into GP, being a Tamil woman, do you think it's an issue for more, like it's skewed more towards women than men, where more women are kind of almost expected to have that work-life balance and going into GP?
I think definitely in terms of, like, you know, Tamil aunties and uncles, they've definitely like told me, oh, it's good you're going into GP, like it's good work-life balance. And I wouldn't say they're saying that from a bad place. In terms of the generation that they were born and brought up in, they genuinely think, okay, like, you know, when you have a family and things, it's good for you. But I think, you know, that if I was a boy, they wouldn't say that to me, but they're not coming from a bad place. But I think there is definitely that girls are kind of advised to go into GP a lot more. I think in terms of my parents, I'm quite lucky in that, like, my dad wanted me to become a surgeon, so he was disappointed, and I was like, this work is too much for me, I want to be a GP. I think he wanted me to be a pilot at one point. So my parents are very kind of, I know if I was a boy, if I had a brother, I have a sister, if I had a brother, my dad especially would say the same thing to both of us. I think my mum was a bit more happy I was going into GP because she kind of sees how I look after, like, on calls and nights, and she's like, why would anyone want to do this? I think she advised me against medicine anyway, because my sister does pharmacy, and she says, I think that's so much of a better job, like it's not this stressful. It was one of my obs and gynae consultants. She's like an amazing consultant and has a family of 4 kids and a dog as well. And she looks amazing every single day when she comes into work. So people do it all. But definitely, I think you do get people telling you, oh, well, yeah, it's better for family life. Yeah, I mean, that does exist.
Thank you for giving us your opinion on that as well, because I think that is a current trend that's been going on based on, like, what I've heard as well. So thank you for sharing your thoughts on that. So going away from the hospital and GP, I know that you have a social media account where you share your work-life advice and balancing and everything. So where did that idea kind of stem from?
I don't know, really. I mean, I think I'm someone who just posts a lot on social, like even on my own, like, personal account. I put everything on my story, and, you know, like if we go out to eat, I'm the person who gets out my phone. It's like, guys, no one takes a bite of their food before I take a photo. So I think because I'm just so on it with social media, I think my friends were like, oh, like, why don't you start an account like this? So I just did it. And then sometimes now, after I started it, I'm like, oh no, like I actually don't know what to post or what to do. But it's nice because you get like other medics follow your account, and then when I kind of complain about an on-call or like a really bad shift, people kind of reply off it being like, we've had the same experience. So I think in that sense it's really nice. I really do feel like you're all in the same boat.
I follow Lavanya's account on Instagram, so you guys should follow it if you guys do have Instagram.
என்னை வச்சு ஒன்னும் காமெடி கிமெடி பண்ணலையே.
Because you post a lot of things, you know, like your work life, travel, food. So I think it's really, really nice to have, it kind of humanizes medics, I think, rather than just being like, okay, hospital,
Yeah.
to kind of also kind of gives raw opinion on how bad the shifts are, because I think a lot of people don't really realize the realities of it, especially as medical students.
Definitely. Yeah, exactly. And I think also the fact that I think when I kind of was going into F1 and F2, people were like, you're going to be working all the time, you're not going to get any time for travel and all of those things. But that's such a myth. Like, it's so doable. Like, you can go on so many holidays as an F1 or F2. You just need to strategically plan your annual leave around like 0 days and things, and it's so doable. So you shouldn't let kind of being a medic stop you from living a life. It does a bit, but not too much. It's slightly, but not too much. Yeah, and it's you can do it all.
Well, thank you so much for coming and sharing all your thoughts and opinions and experiences so far. I think, you know, listening as a medical student or as a resident doctor or even as a non-medic, it's always nice to kind of shed that light. So thank you for doing that. Hi guys, welcome to our second segment of this episode where I'm going to be testing Lahvanya on some PassMed questions. Okay, she doesn't look too happy, but we have 10 questions, and each question you're going to have 10 seconds to answer.
Okay, do I get options?
No, there's no options.
So it's worse than PassMed.
There's no options, unfortunately.
Okay,
but it's only 10 questions.
Okay,
so
fine.
we can do this. Okay, so the first question: what criteria is used to determine whether a sore throat is more likely to be caused by bacteria or not?
Central criteria.
Yeah, yes. So that's something you need to know as GP.
So very GP orientation question.
Okay, second question. The tympanic membrane having a flamingo tinge indicates what condition?
Flamingo tinge. Otosclerosis?
Yes. Third, what is the definitive management of pheochromocytoma?
Like medical or
Definitive management.
removing the adrenals, I guess.
Yes.
Yeah?
Yes. Number 4, what does the replacement of squamous epithelium by columnar epithelium in the lower esophagus represent?
Barrett's.
Yeah. You're doing great. 4 out of 4. Number 5, HNPCC is commonly associated with which type of cancer?
Colorectal.
Yeah. Number 6, what is the first line management of hemochromatosis?
You just remove their blood, right? Like, you just draw blood out.
So what's the procedure called?
Venesection?
That is correct, but your time was unfortunately up. Venesection, yeah. Number 7, which antibody can be positive for patients with primary sclerosis cholangitis?
P-anchor?
Yes. Number 8, which element is increased in deposition in patients with Wilson's disease?
Copper.
Yes. 9, what syndrome can a stroke affecting the basal artery lead to?
Hemianopia.
Nope. Lopton syndrome.
Lopton syndrome.
Yeah. What eyesight deficit is seen in patients with a total anterior circulation stroke?
Hemianopia.
What kind of hemianopia? homonymous,
There we go.
homonymous hemianopia. I don't think I'm pronouncing it right.
காலாவதியான மருந்து எதையோ காலையில குடிச்சிட்டான் போல இருக்கு உளறிக்கிட்டே இருக்கான் நீங்க அதை பெருசுபடுத்தாதீங்க ஐயா.
But
It kind of reminds you of, in PassMed when you get that recall and you get the 4 questions, and I was like, I know it's one of them, but I need that multiple choice, otherwise I can't do PassMed.
thank God we don't have like a person, asking us questions. Well, I hope this podcast doesn't give anyone ideas to change. Hi guys, welcome to our third and final segment where Lahvanya will be talking to us a bit more about an interesting case that she saw and a learning point that we can all kind of learn from.
Okay, so an interesting case. So recently when I was on a ward cover shift, we had a patient, it was an AMU shift. We had a patient come in and this gentleman had been clerked in and the clerking team had written query sepsis source. We don't know where the source is, but he had a bit of chest pain and a raised D-dimer. So we were all very focused on the fact that this man has a PE. His CRP was very high, he was tachycardic, but he did have a temperature as well. So it was kind of sepsis or PE is what we had in mind. But chest x-ray was clear and his urine dip as well was negative. So I think me, definitely, I was very kind of, okay, because the D-dimer is high, it's going to be CTPA, and it's going to be a PE. Obviously, in hospital, unfortunately, CTPAs don't happen as quickly, so it was a couple of hours later. He went in for a CTPA and it was negative, which I think was something that we weren't expecting because we were like, okay, what does this man have? Obviously, we'd sent off blood cultures, but it takes ages to come back. It's not going to come back immediately. And this man was, I think he had a new score of around 8 or 9. He was very unwell. He was getting quite confused, very tachycardic. His blood pressure was dropping. So we started, sepsis 6. He was already on broad spectrum antibiotics, but we really needed to figure out a source. And the clerking team obviously took a history, but then we went back to the relatives and we were like, was there anything that he's complained of? Me and the reg, and she said, oh, he did actually have a bit of hip pain recently. He had a bit of hip pain recently. We thought, okay, and we examined his hip joint, and it was quite warm, but he wasn't really reporting any pain. So it was a bit far-fetched, but we suspected septic arthritis, and we called ortho. Ortho took an aspirate, and it got sent over to the tertiary hospital, and it came back as it grew, I think, Staph aureus. So it came back that he did have septic arthritis, and then we were able to start him on the relevant antibiotics after speaking to micro, and he got better. But I think a really big learning point from that for me was, I think my kind of mistake all the time is when it comes to diagnosis, I focus on one thing and I stop kind of keeping my mind broad. But I think it's really important to still be considering this can be infection, and most probably is. So what else could the source be? And always consider things like septic arthritis, because I think I really thought this patient would have loads of hip pain and it would be really obvious that hip is the site. But until we undressed him and felt it and examined it properly, we wouldn't have suspected septic arthritis. So I think always think of every single potential source in terms of where it could be for sepsis, and keep your diagnosis broad until you've definitely got one. Is I think what me and my reg kind of reflected after that.
Yeah, I think the high D-dimer probably threw everybody off, as it would have, especially with the symptoms and signs you've described.
Yeah, and I'm kind of silly in that sense. When I see high D-dimer, I'm like, okay, it's PE, but yeah, that's silly of me. I shouldn't think like that.
No, I think that's something that most people would have went for, because like you said, septic arthritis, I've always learned it from a textbook kind of view, that extreme pain, extreme swelling, and then I thought the presenting complaint would be a hip pain, isn't it?
Exactly. So I think that's one thing as well. We often expect that textbook presentation, but patients really rarely present like that. And
so you have to spend years learning the textbook, then you start working, and then you realize, oh, it's so different.
It's so different. It's so different, which is shocking, really. But yeah.
Thank you for sharing that with us, and thank you so much for coming today and talking to us about your experiences. I think It's something that, you know, a lot of people can reflect on and will definitely help people, whether they're thinking of GP, whether they're thinking of something else, or whether it's completely somebody out of the medical field. Thank you guys, and I'll see you guys on another episode.